So now you're treating a patient that's just come out of a cast because they've had an inversion ankle sprain, or perhaps a high ankle sprain, or perhaps they've suffered a fracture of their medial or lateral malleolus, calcaneus or talus bone, some common orthopedic fracture, either affecting their lower leg or ankle foot. And they've been immobilized in a cast or a boot. Ankle plantarflexion, ankle dorsiflexion is going to be restricted. So we need a non-loaded motion that carefully remobilizes the ankle joint into both plantarflexion and dorsiflexion. Here's a good one. We have the patient turn and face a chair that has no arms and position their ankle somewhat close to the resting position. Okay? And we'll work plantarflexion first. So we just have the patient do a slow oscillation, 2 to 3 cycles per second, to move fluids and move their lower leg over the top of a fixed talus bone into plantarflexion. As we increase the amplitude of the movement, we can start to stretch the anterior capsule of the ankle as we get into the plastic region of the stress-strain curve and place more tensile load on that particular target structure. Sustained stretching can also be done in this position. Now we want to work on limited dorsiflexion due to a stiffness impairment. We bring our foot toward ourselves a little bit and then we come a little closer to the chair. And now I'm at about a neutral position and I just begin to advance the mortise over a fixed talus. I begin to advance tibia and fibula as a unit over the talus. Again, I'm using a relatively slow oscillation, first moving fluids in the ankle joint if this ankle is swollen. And then if I want to get a little further into dorsiflexion, I can stretch the posterior capsule of the ankle with this nice self-mobilization procedure into ankle dorsiflexion and sustained stretching.